Okay, we are going to look at female reproductive, and we're going to start with uterine structural abnormalities and then menstrual disorders. So, if we look at just a quick review of the female reproductive system, let's take a look right at the center, right? If you look right at the center, we can see the uterus and just reviewing the three different layers of the uterus, right? The inner part is the endometrium. Then we have the smooth muscle portion, which is the myometrium. And then we have the external portion, which is the perimetrium. And then I want you to notice that if we look to the right of that, we could see the pubic bone, right? That's the bluish gray structure. So that's anterior. And then on the opposite side, we can see the lower end of the colon, right? You can see the sacrum all the way to the left. And then we have the colon and the anus. So if we look at the positioning of the uterus, we'll see that it is anteroflexed, right? It's kind of projecting forward, right? So we call that anteroflexed. And we could see that the cervix is more posterior. And that's important to know because there are different pathologies and stages that arise when the uterus starts to tilt in different positions. Then we have the urinary bladder with the urethra, and just above, superiorly, above the uterus, we can see the fallopian tubes, the fimbriae, which are the finger-like structures, and then we see the ovary. So when the fallopian tubes get inflamed, we call it salpingitis. Salpingitis. All right, let's take a look at the next slide. And again, just a little more review. If we look at the different layers of the uterus, again, the innermost layer that sloughs off once a month during menses, that is the endometrium. Then we have the middle layer, which is the myometrium. That is the layer that responds to one of the hormones released from the posterior pituitary, and that is called oxytocin. That's what makes the smooth muscle contract during labor. And then the external part would be the perimetrium. Right around at the bottom, we can see the tip of the cervix. So when we talk about cervix cancer, we know what we're referring to. And then we see the rugae of the vaginal canal. We can also see the fallopian tube. We see the isthmus of the uterine tube. The uterine tube is aka fallopian tube. And then we see the fimbriae at the very end. Notice those fingers are not at all in contact with the ovary. It's only at time of ovulation, when LH or luteinizing hormones spike, that the ovary pushes out. The ovary pushes out the egg, and then the fimbriae approximate, move closer to the ovary and act like a vacuum and just scoop it up. And then these cilia beat rhythmically and try and propel that egg in this direction, whereas sperm is moving in the opposite direction to meet the egg in the fallopian tube for fertilization. And then implantation should take place in the uterus. Okay, so let's take a look at the normal positioning of the uterus. And what's important here is we'll see, based on the picture above that I had shown you before, that the uterus is slightly anteverted and antiflexed, and the cervix is downward and posterior. Okay. When there's retroflexion of the uterus, right, the uterus is tipped posteriorly, it may be excessively curved or bent, and that marked retroversion can cause back pain. It can also cause dysmenorrhea. That is a painful menstrual cycle. And then there's my bad, dyspareunia. And dyspareunia is painful intercourse. Now, in some cases, infertility can occur. All right, so here it's important to know that this menorrhea is menses. Dysmenorrhea would be painful menses. When it's amenorrhea, it would be absent menses. Okay, and dyspareunia, that is painful intercourse. So again, if we take a look, back here is the sacrum, right? So this tells us this is posterior, this is anterior, here's the pubic bone. So here is the urinary bladder, this would be the urethra, and now we have the uterus. So when it's anti-flexed, that's normal. Then we see that there are varying degrees of posterior shifting. When it first starts to shift, obviously that would be a first degree. When it rotates even more posteriorly, second degree. And when it rotates even more, third degree. Right now it's pushing up back here against the colon and can actually obstruct with bowel movement. Okay, that is retroversion. It is moving retro, backwards, or posterior. So here again you can see this is a normal uterus. It's anterior flexed. They say 45 degrees anteriorly. Now here it's projected posteriorly. Okay. Here it is referred to as a retrocession. Okay, it's starting to go backwards a little bit. Here is normal. And then what we see here, it's anterflex. So now that it's moving more anteriorly, it can push up against the urinary bladder, creating its own set of problems. So the uterine displacement or prolapse, there's first degree, second degree, or third degree. The first degree of the prolapse, the cervix drops into the vaginal area. The second degree, the prolapse of the cervix lies at the opening of the vaginal area. And in the third degree, the prolapse, if the uterus and cervix protrude through the vaginal orifice. Okay? The early stage of a prolapse can be asymptomatic, and the advanced stages start to cause discomfort. It can cause infection and decreased mobility. Now here we're starting to see the prolapse, where here we have the normal positioning. Then we start to see it retro, and now we see it start to prolapse into the vaginal canal, right? Here is the tip of the cervix. Okay, so you have your first degree, then you have your second degree where the uterus drops through the vagina, and then the third degree, the prolapse is more severe where the cervix is actually outside of the vagina. Now let's look at a retrocele and a cytocele. A retrocele is protrusion of the rectum into the posterior vagina, and that can cause constipation and pain. A cytocele is protrusion of the bladder into the anterior vagina, and that can cause UTIs. Okay? In severe conditions, if severe, the conditions are treated surgically to try and increase the support of the pelvic ligaments. So here we can see the urinary bladder bulging into the vaginal canal. Okay, so here we see, here is the vaginal canal, here is the uterus, here is the bladder, and it's starting to push backwards in this direction. Okay, now here we start to see, here is the rectum, right? Here is the end of the colon, here is the rectum, and now this is bulging into the vaginal canal. So in this case, you have the anterior structure pushing back posteriorly, and then in this one here, we have the colon and the rectum, and that's starting to bulge and push anteriorly. Right, here's the uterus, here's the fallopian tube, here's the egg, and it's starting to obstruct the vaginal canal. Okay, so here you have the uterus and you have the vaginal canal. We either have the urinary bladder that's going to push back, or we're going to have the rectum and the colon that's going to push forward. All right? The cytocele, the cyst is like the sac, that's the urinary bladder, and rectocele from the rectum pushing anteriorly. So amenorrhea, remember we said menorrhea, that is the menses. So A, whenever you put A, it means absent or without. So amenorrhea is the absence of menstruation. Now there could be a primary form where the menarche never occurred. There are genetic conditions like Turner's syndrome, where there could be absence in menses. There could be defects in the central neural system and its development, especially in the hypothalamus or in the pituitary, that is involved in different types of sex hormones that can affect it. Or there could be a congenital absence of the uterus. There's a secondary form of amenorrhea. This is when the menses stops. There's cessation of the menses. And this could happen secondary to hormone imbalances. There could be activity of the hypothalamus that may be affected by perhaps a pituitary tumor, abnormal stress that's throwing off the hypothalamic function and the pituitary function, sudden weight loss. We know that there are issues with different types of eating disorders as well that could lead to fat loss, and when fat percentage drops below 10 or 11%, maybe even a little bit less, then that can also be a major cause of amenorrhea. We know that amenorrhea can happen in very athletic women, where the body fat percentage really dips below. Okay? And we've also seen it in thyroid imbalances when there's irregularities to a menstrual cycle, where it either goes absent or maybe even twice in a month. That could also be indicative of a thyroid imbalance. Now, dysmenorrhea, this means there's painful menstruation. Now, primary dysmenorrhea, this is caused by excessive release of prostaglandins during the endometrial shedding. Remember prostaglandins, the PGs that come from the arachidonic acid? Prostaglandins cause strong muscular contractions, and they can cause vascular ischemia. And what typically relieves the pain is when someone uses NSAIDs, because NSAIDs, the non-steroidal anti-inflammatory drugs, decrease the production of these prostaglandins. Okay? Prostaglandins also create fever, so when you take NSAIDs, it brings down fever. Prostaglandins decrease pain. They decrease mucus contractions. So NSAIDs, the non-steroidal anti-inflammatory drugs, decrease the production of prostaglandins. The secondary type of dysmenorrhea, this is caused by different types of pelvic disorders. Endometriosis, which we'll talk about shortly. There's uterine polyps, and PID, which is pelvic inflammatory disease. These are all secondary causes of dysmenorrhea. All right, let's talk about PMS, premenstrual syndrome. Remember, a syndrome is a concoction of a bunch of different clinical symptoms that tend to show up at one time, not just one thing, but many things. So it begins approximately a week before the onset of menses, and it's believed to be related to hormonal factors. Some of the symptoms are breast tenderness, there's weight gain, abdominal distension or bloating, irritability, moodiness, mood swings, emotional liability, sleeping issues, depression, headaches, fatigue. The treatment here is usually pretty much individualized, and it may include exercise, limiting salt intake, the use of the OC, the oral contraceptive, diuretics, and antidepressant drugs. Again, these are not curative by any means. They are designed specifically to address symptoms, right? And that's something that's really important when we educate patients. It isn't a fix. All we're trying to do here is trick the body and to alleviate symptoms. And that's really important. It's part of informed consent. Okay? Abnormal menstrual bleeding. So it's important to be familiar with these terms: menorrhea, menorrhagia, polymenorrhea, and oligomenorrhea. So menorrhagia, this is when there's increased amount of menses. So increased amount of bleeding and duration of flow. That's menorrhagia. Metrorrhagia is bleeding between the cycles. So perhaps instead of once every 28 days or one menstrual cycle every 30 or 32 days, maybe it's every 15 or 16 days. And then there's bleeding between those cycles, metrorrhagia. This could be seen typically with a lot of thyroid imbalances. Okay, not the only thing, but it tends to be a major thing. Polymenorrhea, this is when a woman has shorter cycles of less than 3 weeks. Oligomenorrhea, these are longer cycles of more than 6 weeks. Okay, we're still on menstrual disorder, so let's look at endometriosis. This is pretty common amongst women. Endometriosis is when there's the endometrial tissue. Remember the endometrium, myometrium, perimetrium. So this is the innermost layer that is nutrient rich in carbohydrates, proteins, and fats. It is epithelial cells. When the endometrial tissue occurs outside the uterus, okay, that is endometriosis. Ectopic endometrial and the ectopic endometrium responds to cyclical hormonal changes. So bleeding leads to inflammation and pain. The fibrous tissue may cause adhesions and obstructions of the involved structures. The etiology, there's possible migration of the endometrial tissue through the fallopian tubes. Development from embryonic tissue at different sites, that's pretty common. It's spread through the blood and the lymph, but endometriosis is not a result of a sexually transmitted disease. It's not an STD, endometriosis. And typically, it can happen from a transplant of endometrial tissue during surgery. Okay, so again, the endometriosis is when the endometrial tissue occurs outside of the uterus, and the ectopic endometrium responds to cyclical hormonal changes. With endometriosis, there is dysmenorrhea, right, painful menstrual cycle, and dyspareunia. Dyspareunia means painful sexual intercourse. Treatment is going to be hormonal suppression and surgery to remove the ectopic tissue. That's just a picture of endometriosis. Here's the endometriosis. These are all these ectopic sites, right? So look, everything that you see green here, these are all possibilities of ectopic sites. Okay, we're going to pause here, and when we come back, we'll get into female reproductive infections and benign tumors.